Thank you so much. I want to thank the AES for giving me an opportunity to come and share with you what I've observed in clinical practice over the last 9 years looking differently at periodontal disease. What I didn't realize is that my patients started to learn about periodontal disease and inflammation in 1984. Time magazine came out and talked about the significance of inflammation and how harmful it is to the body. Recently, there's been more collective works on this topic. And in this book, Inflammation Syndrome, which is in every operatory in the practice so we can have a visual culture, it talks about how medicine is redesigning vascular disease as an inflammatory disease of the blood vessels. And with this brings a great opportunity for us. It's been highlighted several times this week because it's the bugs that live around the teeth that give us a unique opportunity in clinical practice. And this is our wheelhouse. This is where we spend our day, and this is where we should be experts. And so we can be, and that's great news for us. So when I started to look at periodontal disease and how it affected other systemic conditions or how it may affect other systemic conditions, I realized my patients that were coming to me for teeth issues also wanted some kind of health balance in their lives. And they really wanted to be healthier, but all I had to do was say the words. I had to give them the opportunity, and that's what we did. And it evolved through the understanding of this model. So I want to make sure everybody clearly understands, and especially our hygiene teams in the room, I want to make sure we clearly understand this model of how this disease progresses. It starts with the microbial challenge. There's not one paper written that I know of, maybe Michael can help me if there is one, that doesn't mention a microbial challenge. What I didn't know about the microbial challenge is that it often contains yeast and viruses as well. And it's the microbial challenge that stimulates a unique host immunoinflammatory response that's made up of your genetics and how you live your life. And it's that response that determines whether this disease stays confined to the gingiva and is called gingivitis, or whether this disease goes on to create a dysregulation of bone metabolism and becomes periodontitis. And it's a very unique process. And what could we do? We could intercept it early in the game, but we have to work in the green box. We have to work in the microbial challenge box. So what I intend to do in the next 45 minutes is talk about how salivary and molecular diagnostics that we use in practice has assisted me in disease management. How obviously we've learned that oral inflammation, and to Michael's talk today, maybe I would cross the S off of contributes and I would put contribute, and maybe after inflammation I would write may contribute to the vascular disease process. I happen to believe we have enough research to significantly go after this disease. Also, there's unexpected realizations by using metrics that I've applied to this model, and it's been very revealing for me, and we approach the disease very differently. And it's allowed me a great opportunity to collaborate with physicians. That's been really, really rewarding, and I want to share that with you. So the bottom line about this disease, and if you want to have a very simple understanding of it, it's really easy because it's a biofilm-induced host-modulated disease. Kim Cooch talked earlier today about caries. It's a biofilm-induced disease. And in fact, I feel there's only 2 diseases in the mouth that we have to worry about that are biofilm-induced: caries and periodontal disease. And some of the treatments similar, quite similar. What I used to do in practice is I would wait for clinical signs of the disease. I would collect some data. And I'm embarrassed to say that early in my practice career, I didn't even really have accurate periodontal charts. But I would collect this data, and I would wait until the disease outpaced my skill level, and then I would refer. And oftentimes a periodontist would say to me, "Why did you wait so long? Why couldn't have I seen this patient earlier? I could have done something more for them." So to a lot of what we've heard today, early disease detection is important. And so we're trying to identify and work with this disease much earlier. So the only place I could apply good metrics other than a periodontal chart and some clinical data is starting to look at a microbial assay. Would a microbial assay be valuable? Today, there's 3 companies that provide reliable, affordable, accurate assays for us. And at the time, there was only one company when I started doing this, and then there quickly became two. I started this in 2009, and it was how could I apply this metric to the microbial challenge box, and what would I learn if I did that, and how would it change, or how could it change the treatment that I rendered to my patients? And then I saw this study, and what I realized is when I was taking microbial samples, which were rendered using PCR DNA analysis, not culturing, which is different than times of past, that I realized I was personalizing the infection for the patient. I was giving them personalized clinical data about their infection that hit home with them. And in 2015, this small study came out, and it confirmed what I was seeing in my patient population. That when I personalized the infection for the patient and talked to them on different terms, they started to think the disease was more serious. They also thought that my treatment plan would be more effective, so I had higher treatment acceptance. They also felt more comfortable about the treatment recommendations that I was going to make, and they felt like they would be able to do what I was asking them to do. And they felt positive about the whole disease diagnosis experience, and they felt comfortable about the overall approach to management. So I learned that personalized risk communication and personalized disease communication is essential to motivate changed behavior and to motivate patients to do something differently than I had been doing with them in the past. Because there's two key things about this disease that determines the rate and progression. It's the microflora composition, what's it made of, what's stimulating the host, and it's the host modifying factors. So if we're looking at those two things, we can start to really understand the disease at the microbial insult level, and we can start to decide, are there opportunities at the host modulation level, or are we going to work in the microbial insult area? So I treated some cases using microbial metrics. And what did I find? I treated this case just like I would traditionally treat a case, and I was so happy because the perio chart looked better. I have practitioners that come to me all the time and say, you wouldn't believe them. I did the periotherapy. It looks so much better. Looks better, but no metrics. Maybe a perio chart. I redid the microbial assay, and this microbial assay is a before and after, and it looks like I wasn't even there. Looks like I didn't even alter the biofilm at all. And then I started to go back and think about what I learned. I was proud to go to University of Michigan, and I'm proud to have a daughter that graduated from University of Michigan and ultimately wore a sports uniform for that team. And how proud a dad could be seeing their college daughter in a sports uniform. But they taught me at Michigan that I should scale the teeth. Ultrasonic scaling would be best. Maybe use some hand instruments. And I should have the patient rinse with chlorhexidine. And at the end of 6 weeks, we would have them back for what we call hygiene phase completion. You were done. They were going to be better, and you were going to put them into maintenance. And you were going to base the maintenance based on their perio case type classification. And you were going to reserve the use of antibiotics or any kind of antimicrobials only in cases where there's severe disease. You weren't using it routinely. Well, I learned that what I learned at Michigan was it was a great way to take care of healthy teeth. But it wasn't a very good way to take care of diseased teeth. That's a different animal. And that's what I hope to share with you. And I learned this about the mouth that I totally overlooked. John, I treated John, and on the top is his pre-treatment periodontal metric or microbial metric, and on the bottom is his post-treatment metric. And I asked people in the room, what do you see in that metric? And most of the people will say, well, I see the same bacteria, but they're less concentration. I said, that's exactly right. That's what's there. Guess what the treatment was for John? I took out his denture. He doesn't have teeth. Why do we think the bacteria just live on the teeth? Hygienists don't have the beauty of taking out the teeth and cleaning them on a bracket table and putting them back in. But the idea is bacteria live in a lot of other places than just the teeth. But at Michigan, I was treating the disease with a curette. I only curetted the teeth. I wasn't doing anything else for the rest of the mouth. And I started to think about this biofilm disease, and maybe it's a little more tenacious and we have to go at it in a different way because these bacteria don't just live on the teeth. They live in crevices in the tongue crypts. They live all over the place in the mouth. And so we started to recreate our vision for perio. We needed to have a different vision. And this is what the leader of the practice does, is establishes this vision. I wanted all patients to have a comprehensive exam. I wanted disease to be identified very early so we could attack this microbial challenge earlier in the game. I wanted to make sure that we did talk about whatever health awareness data was out there that we could use to help the patient understand this disease had potentially other issues. And I wanted to personalize treatment options any way I could, because I learned that personalizing clinical data was really, really significant. And I also wanted patients to respond to a therapy that was predictable and that worked. And I wanted maintenance protocols that worked and that a patient could adhere to, because what good is it if the patient can't follow the maintenance protocol? And so we developed that policy, and we developed it around clear criteria about how to diagnose the disease, what data we needed to collect, and we did it around these 5 areas. And I'm going to go on to share with what we learned from that. Many of you, I know we heard the word, are you an exceptional dentist? Many of us get these accolades, whatever the place may be that you get them from in practice. But I can tell you this, I'm not an exceptional dentist. I have an exceptional team. And perio is a team sport. Biofilm disease management is a team sport. Health and wellness in the restorative practice is a team sport, and we need our teams to be on board. So if you happen to visit me in the exhibit hall and you wonder why I have 2 people traveling with me, this is Veronica and Diane, our periodontal therapists in the office. And the idea is we need our teams to speak to each other and have peer-to-peer teaching and peer-to-peer learning. That's how we create real change in our teams. It's very difficult for you to take the information back to your practice and initiate this with your team, and that's why we need help in doing that. So we decided that we would take a much more robust approach to this disinfection process, and we know we needed to do it in the office, and we need the patient to do it at home. And the goal in the office is to disrupt or remove this biofilm to a significant balance that doesn't stimulate the host immunoinflammatory response. And we needed to do it on the teeth. We needed to do it in the crevice around the teeth. We needed to do it in the fluids that flow out from around the teeth. And we needed to do it in the cheeks, tongues, and tonsillar areas and the rest of the oral cavity. We need to make a much more significant splash at doing this. And there's methodologies that I'm not going to go through in detail to do it, but they're listed for you. I also want to make sure everybody in the room realizes that this whole entire PDF presentation is downloadable for you. So don't fret about the number of words that are written on the slides. You have this if you can download it from our website. And then we have to talk to the patient about how to do this at home. We need to have a methodology at home to remove the biofilm from the tops of the teeth and the sides of the teeth. We need to remove the biofilm from in between the teeth. We need to remove the biofilm from the areas around the teeth, and we need to remove the biofilm from the cheeks, the tongue, the rest of the oral cavity. And how do we have to do it? Mechanically and pharmacotherapeutically. We need mechanical debridement and chemical debridement as well. And so I'm going to outline that disinfection protocol for you in just a second. In 2012, Jorgen Slotz published this paper, Low-Cost Periotherapy. And this became a confirmation paper that what we came up with in 2009, in fact, had some good merit. And in the Slotz paper, Jorgen Slotz says that to achieve this environment, we need to get rid of the pathogenic microorganisms. We realize that out of the 600 to 700 species of bacteria that live in the mouth, there's only about 15 or maybe 20 that are widely implicated and studied in periodontal disease, so those are the ones that are currently on these metric tests. We're starting to add more. And that you have to have mechanical debridement and chemotherapeutic options because they're both important concepts of treatment. And what the goal is to either eradicate, suppress, or alter the combination of pathogens to some level that relates to health. What's health? Health is zero bleeding right now on a periodontal chart. That's the best metric I have. I have a pick and a stick that I work with. And that's the best metric I have is inflammation and bleeding on perio chart. And so we know that what Slotz goes on to say is that routine scaling and root planing without the use of chemotherapeutic agents has little effect on the disease. And I've in fact found that to be true. So in the paper, he goes on to say, what is the best disinfectant? What kind of disinfectant should we use in the mouth? And we had 3 basically halide disinfectants. If you remember the periodic table of elements from high school, way over on the right-hand side of the chart, there were the halogens. That's iodine, fluoride, bromine, chlorine. These are highly reactive species, and so our best disinfectants come from that group. So we evaluate in this paper povidone iodine, chlorhexidine, and dilute sodium hypochlorite. And what he concludes in the paper is that sodium hypochlorite is antifungal, it's antiviral, and it's microbicidal. It's a perfect disinfectant for us to use. Nobody has an allergic reaction to it. It's not a carcinogen. It doesn't impair fibroblast healing. It has a high pH. We've been using it in our hospitals, drinking water. It's been used all over the world as a great disinfectant. Where did that disinfectant came out? It actually came out in about 2009. Kim Cooch has been working with it for 15 years. I've been in personal communication with Kim for years about the best disinfectant to use and the studies to show it. It has a broad antimicrobial activity, and it's hugely effective at stripping or reducing biofilm. And that's why we use this product. The American Dental Association says it's fine to use on mucous membranes if it's diluted, and the dilute concentration is 0.2%. And its basic pH doesn't pose a risk of tooth erosion, doesn't corrode titanium, no detrimental effects on healing. As I stated earlier, there's no contraindications to use. I threw chlorhexidine out of the practice about 9 years ago. I have oral surgeons that are having their patients rinse with dilute sodium hypochlorite, and we have a beautiful FDA-approved product that's been provided for us. It's out there in the market. You can find that. So I've provided you the disinfection modality that we created, and I've written it out in exquisite detail, and it's available for you to look at. This is where we start with disinfection. This is where we start. This is not where we end. This is where we start. We use this disinfection modality, and we keep patients on tight 2-month recare. If for no other reason, keep patients on tight 2-month recare, do it for education reinforcement, because stretching patients out to 3 and 4 months and beyond is too long. It's just too long. And until patients are very stable, keep them on very tight recare. So the disinfection protocol is there for you. And what we've learned through looking at these 5 different areas is that we can take a closer look at microbes, and we can take a closer look at genetics, and it affects the way we treat patients. Our microbes, as I stated earlier, we now should be considering yeast. I think Kim cited a paper where yeast is a component of a lot of early childhood caries, and it's not outside the concept of practice. I put children that have early childhood caries on a nystatin amoxicillin rinse. Strep mutans and oral bacteria are very susceptible to liquid amoxicillin. It's swish and spit. And so we have to start thinking about nystatin or about other potential yeast treatments, other viral treatments, and then obviously what can we do with the genetics? When I started doing this, I only had IL-1 as a genetic component to look at, and now we have nice panels of genetic biomarkers or SNPs that help us learn about a patient's innate response and an acquired response to a potential microbial insult. What's also interesting about these genetic companies is they're giving us information about how this genetic profile, if you will, affects periodontitis, how it affects cardiovascular disease, how it also affects type 2 diabetes and rheumatic illnesses. So what's nice about this is our patients are starting to get more information that here you are at the dentist, you ran a test that could help you with periodontal disease, but you also have an opportunity to talk to the patients about how that genetic profile may influence some of these other disease entities as well. And it makes a big difference in how we treat the patient. It also makes a difference in how the expectations of the patient can be tailored to their modifying risk factors for the disease. So we would take someone like Chris, we would do a typical bacteria profile, and we would look at pathogen loads, And I don't use these microbial metrics to tell me if they have disease. I use inflammation on perio charts to tell me if they have active disease. I use these microbial charts to maybe take a better targeted therapy. Do I need amoxicillin and metronidazole? Do I need metronidazole alone? Do I need a rinse antibiotic if the patient has a gut intolerance? I cover all patients on antibiotics with probiotics. I use antibiotics very judiciously. But these metrics help us. And then what we do is we treat patients out to stability. And that stability, we define that as 0 bleeding on a perio chart. If you do a retest metric on a patient with bleeding, you're going to be disappointed. And what I found is some pretty neat things about how long it takes to get patients stable and to get patients to have 0 bleeding and altered biofilm loads. And so we can see nice results on these metrics, and it gives the patient information about why they worked so hard, why they did what they did, and it personalizes this disease for them and this healing for them. So I went back and I took that same patient. We took that same patient that we had no great success on altering the biofilm. And believe me, in 2009, I had to do this quite a few times to start to figure it out. And we retreated them. And we retreated them the way I've outlined. We obviously evaluated the occlusion, and I would go on record in this continuum as saying the occlusion does not cause periodontal disease, but an aberrant occlusal pattern or occlusal dysfunction could aggravate an existing disease. And we would treat them with full mouth scaling and root planing. We would irrigate with a potent antiseptic, a 2% sodium hypochlorite rinse. We would place a timed release antibiotic that we had in the sulcus, and we would put the patient on a 2-month, 1 minute a day rinse. And where that comes from is Kim Kuch's research on the school children, where they rinsed for 2 years with sodium hypochlorite rinse. They rinsed a minute twice a day, and they did it for 2 years. And I didn't know how long it was going to take to alter this biofilm. And then we would prescribe the antibiotics as based on the report, and we would look at them 8 weeks later. And so he came in about 7 weeks later, but we didn't retest because it wasn't 0. There was not 0 bleeding. So we waited. We pushed him out another 2 months. He was still on sodium hypochlorite rinse. And we did a perial maintenance at the time, at that interim appointment. He came back, and this is traditionally what I see. Patients look great. They look a lot better. And now we're out almost 4 months from treatment. And so here's the pre-treatment chart. Here's the post-treatment chart after traditional SRP with the use of chlorhexidine, no antibiotics. And here's the new altered biofilm profile. And I was excited about this because I thought finally we moved the biofilm metric. Now the question is, can I keep it there? Can he keep it there? What would that look like? So we went ahead and looked at him at several junctures along the way. In 2 years, 2 months, he still was looking pretty good. He was keeping his maintenance intervals. And here was his pre-treatment. Now here's his post-treatment chart. And here's 2 years, 2 months. Still a very different microbial profile from disease identification levels. How about 3 years, 4 months, 3.5 years? He still looks very different than he did from the initial disease identification. How about 4 years, 3 months? At 4 years, 3 months, he was getting a little inconsistent between his appointments. So this is where you remind your patient. You can beef up or scale back the process as they're going along. You could have them add things to water picks. You could do different things to strengthen your treatment regimen if you see him starting to fall off a little bit. He wanted to quit smoking at this time. And again, a very different microbial profile. How about 6.5 years? 6.5 years out, still looking great. This perio chart on the right is an 8-year perio chart. He still comes in consistently with 0 bleeding, time after time after time. And in January, I collected 9-year post-treatment data. 9-year post-treatment data, we still show a significant different biofilm. Len was on antibiotics 1 time, 9 years ago. What was different between the 9-year disease presentation and now? He had tight periodontal maintenance. He had strict home care. He was totally re-educated about what he needed to do to take care of his diseased teeth. People are sometimes embarrassed because we use the word oral hygiene instruction. I would reassure them, oh, you know how to take care of healthy teeth. We just need to show you how to take care of diseased teeth. It's very different. And you shouldn't know how to do that because that's not what you've been taught before. And so I think this is very compelling, and we've repeated this time after time after time on other patients as well. So we have a lot of data now. We painstakingly looked at whatever data we could collect, and I would go on the record as saying, I'm not a scientist. I don't know how to read the research. I can only tell you what I think I see in the research, and I can tell you what the microbial metrics has helped me do. It's helped me totally reframe my approach at disinfecting patients and talking to them through maintenance phase to keep them clean. And here's what I've learned. I've learned that measuring microbes personalizes the infection. And for that value alone, if you don't believe in the metric, you don't want to use it because you think the studies aren't accurate. And by the way, if you took that bacteria sample the same day on the same patient and you turned it in under a different name, or you took it a week from now or a month from now, I can tell you the biofilm is pretty stable. It's either diseased or it's not diseased. It'll stay pretty consistent. And I've ran 3 companies next to each other. They're strikingly similar. So it's not that far. It's a pretty reliable metric. When you communicate the host immunoinflammatory response, it's really huge because you have to then tell the patient it's not only the microbes in your mouth, but it's these other things in your life. Do you smoke? What's your nutrition like? What kind of sleep do you get? Are you hydrated? Do you exercise? Does your spouse contribute to your biofilm load? All these things we have to take into account. And we get an opportunity to discuss the inflammatory response because in a minute I'm going to share some of the stories that we share with patients about how this disease may impact other diseases, what that might mean. And we get increased treatment acceptance. We know we have to treat the entire mouth, not just the teeth. And we know we need to keep these appointments very short until the patients get stable. Once they get stable, then you can push them out a little bit longer. No retest until there's 0 bleeding. I know biofilm is not easy to use or not easy to manipulate. I've learned there's 3 main areas where we treat biofilm diseases: the mouth, the respiratory tract, and the gut. I've studied some functional medicine through the American Academy of Anti-Aging Medicine, and no physician in that continuum thinks you can treat a biofilm disease in a few months. They all think it takes a lot longer, and I think we should be starting to think about that at the mouth as well. We know we can improve treatment outcomes and increase stability, but here was the big thing that I learned. I learned that the average time in our practice to get a patient stable is 4.5 months. So if you're telling your patients they're going to be better in 6 weeks, it's not going to happen from a biofilm standpoint. That's not what our experience has been. We set patients up and we tell them this is going to take a while. How long? I don't know. It's based on your risk factors. It's based on your biofilm load, based on your ability to manage the disease at home. It's going to be very personalized for them. But the average time in practice is 4.5 months for us, over hundreds of cases. Now we have another opportunity. We have this other opportunity about inflammation and what it might mean to the people who are authoring these books. All the authors of these books agree that we need an oral provider to help evaluate the mouth because there's some science that suggests, and some science that now maybe even more concretely suggests, that what's in the mouth can affect vascular biology. And we know we have vessels that run in, as Amy and Brad told us yesterday, 60,000 miles of vessels in the body, so we have a great opportunity. I don't need to go into this in detail, but we know that way over on the left, we could have a normal vessel, a normal vessel wall, and as we give our body the building blocks of atheroma, we start to build atheroma. And that atheroma typically expands outward for quite some time, and then it starts to encroach inward. But more importantly, we know that that plaque cap that was so eloquently described yesterday, that plaque cap can become unstable. What can make that plaque cap unstable is inflammation. And what the beauty of this process is, we have biomarkers that we can measure. Biomarkers that we can measure that give us a hint about how the patient's doing and the ability to manage their cumulative inflammatory burden. And we know that periodontal disease, or at least there's some studies that suggest that periodontal treatment can affect vascular elasticity. It can affect the function of the endothelium. It can affect the ability of HDL to do its job. It can affect the atheroma process. It can also, we know these biomarkers, I don't need to go into them, but I do, we went into them yesterday. but we can look at these and it can help us determine how well that patient's doing in managing their inflammatory load. And so Cleveland Heart Lab has its inflammation panel, and other labs have this as well. And so this can help us give us an idea how inflamed that patient is. And we learned yesterday that through Brad and Amy's work, they feel so confident in measuring these biofilms that they can really guarantee wellness in their patient population. I think that's pretty incredible. And I hope to watch that play out over the next several years. But their recent study about 8-year outcomes following their methodology, and I recommend everybody take this course, their preceptorship course, is that this is an effective methodology. And what I'm trying to do is parallel a periodontal methodology that's been very effective for us as well. And I think it's important to have these. And what Brad and Amy also teach us that I didn't know before I took the preceptorship course is that there's things I can see in my patient population that might give me a hint if they have a higher risk for cardiovascular disease. And that's beneficial for me because look at the list: stress and depression, lupus, psoriasis, elevated uric acid, gout, hypertension, resting heart rate, insulin resistance. A lot of my patients have several of these. If they have these and they have periodontal disease, I'm having a different discussion with this patient because this is what we want to prevent. Every 34 to 40 seconds, somebody dies. We don't want any of our patients and surely any of our family members taking this ride. That's what we want to prevent. And so I would give you a review paper. I'm not smart enough to look at all the individual papers, but I do have a really nice review paper. And when I look at a systematic review paper, and this is a really nice one, this talk looked at 152 different references, and it looked at commonality between cardiovascular disease and periodontal disease. It involves the innate and the adaptive immune system. Cardiovascular disease does. Sounds like perio. And what initiates it? Bacteria. So this paper reviewed 40 papers. It looked at how periodontal disease affects biomarkers, 16 on blood characteristics, 19 on antibodies, and 22 on lipids. 97 papers overall, suggestive that periodontal disease affects cardiovascular disease. I don't need any more than that in my practice to start to go after inflammation differently. What I learned in Michigan and what I learned about periodontal management was to prevent tooth loss. I have a different concern now than tooth loss. I have an inflammation concern. And I think we have enough references to show that. And this, again, I don't need to explain this because this was Brad and Amy's paper discussing how they think periodontal disease pathogens is causal of some change to both serum lipid concentration, smooth muscle reaction, and endothelial permeability. And so these are pieces that we can look at to give us confirmation that we have the right to go after these pathogens, and we have the right to know what these pathogens are so that we can attack them more aggressively. And if we look in the medical literature, most of these medical reference papers are looking at specific pathogens by name. And many times we don't even look at the pathogen load by name. But Fusobacterium nucleatum, Porphyromonas gingivalis, AA. And then how about this? Can oral infection be a risk factor for Alzheimer's disease? It's amazing. I could probably take the same information for periodontal disease, and if you look at Dale Bredeson's work, I could apply it to Alzheimer's disease, and it would be the exact same thing. Additionally, it's under the radar right now, but Fusobacterium nucleatum is widely implicated in colorectal cancer. So there's some really nice suggestive papers out there that gives us good reason why we should be looking at bacterial loads and trying to control these biofilms in our patient population differently. So Joan comes into my practice. She has periodontal disease. She was referred to me by a periodontist because I did yeast testing and he didn't do yeast testing. She has other risk factors for disease, diabetes, increased adipose tissue, hypertension. She hadn't seen a physician for a while. She says, I manage my diabetes through my diet. So I was concerned about Joan. So I sent her to a physician and he did a Boston Heart report. And you can see by the red, yellow, and green, there's obviously some concerns. Why I wanted to share this with you is to show you how this report was broken down. It's broken down into lipids, inflammation, metabolics, and genetics. If you replace the word lipids with pathogens or biofilm, this is basically periodontal disease. It's the exact same kind of process. The report goes on to is to be very personalized for Joan, and it has her name right on the top of the report. Joan, you're in danger. Why? Because she has a severe dyslipidemia. She has a severe dyslipidemia. But more important than just having the building blocks of atheroma, her inflammatory panel is very elevated. Some of the highest risk inflammatory markers, myeloperoxidase, LPPLA2, some of these are not disease risk indicators. These are disease activity indicators. So we know that she has a significant risk. And what this report goes on to tell Joan is, Joan, if your inflammation is not addressed, you have an increased near-term risk, 1 to 6 months, of a heart attack or a stroke. Now, if you're the dentist that finds this out in your patient population, they'll look at you very differently than somebody who can just replace or replace a restoration. So how I use this in screening is a case like Charlie. Hasn't been in to see a physician in quite a few years. He obviously has a lot of dental disease. His disease was caries. His disease caused a lot of structural compromise to the teeth. He has a lot of needs for restorations. I have no idea his inflammatory status. I have no idea of his cumulative inflammatory burden. And I have to extract 6 or 7 teeth, put in some transitional appliances, and plan for what the next steps are going to be for him. A lot of his periapical infections are caused by structural compromise due to caries. So what can I do for him? Obviously, this is his perio chart. He's potentially in trouble, but I don't know. Before I go in and do a lot of invasive cleanup work, I would like to evaluate him and know what his inflammatory status is. So what we can do now is we can collect these medical metrics, and I'm not going to go into the details in the interest of time, but you can see all the green boxes. The green boxes assure me that his most high-risk, dangerous inflammatory markers are green. And he does have some endothelial issues, and he has a lack of vitamin D and some of his omegas, or just his omegas. But this gives me a pretty green light to work on Charlie. I can go ahead and do what I need. And so what we're starting to do in practice and in our network is collect this data. We're collecting it pre-treatment, a month after treatment, 3 months after treatment, and 6 months after treatment. And I hope we can compile a series of medical metrics that help correlate the data in this sometime out in the future. That's what we're hoping to do. And that's what I think we're going to end up being able to do. What about medical cost savings? I know Michael's back in the room. I'm going to go back and show the Jeffcoat study. It's already been shown, but I'm going to show it for a different reason. This is the Jeffcoat study, and if you recall, it was a combined claims database. They looked at people who had periodontal disease and who had one of 4 or 5 different conditions: diabetes, rheumatic arthritis, cerebral vascular disease, coronary artery disease, and they looked at pregnant women. And what she looked at there was people who had 4 or more perio codes, and most of the codes, it was either a prophy code or a scaling and root planing code in the baseline year, and then watched over the next 5 years what happened. But I'm not showing this for this reason because you already know the result. There was this study happened to show significant cost. But in the data table, when I looked at it, I saw some disturbing numbers, and I'll summarize on the next slide. In this study, there were 338,000 patients that were evaluated. 205 of them had one of these diseases or illnesses and had periodontal disease. But unfortunately, our dental profession only produced codes that suggested 1% got treatment. And guess what I find in private practice when I go around the country and talk to people about perio? I ask them, run the codes. What % of your patients do you think are in perio maintenance or in some kind of perio service? It's tragic. It's usually less than 5%. I offer a Starbucks card if it's over 5%. No, I haven't given one out yet. We need to think about what kind of coding we're using and what we're doing, because either the perio is being treated and not billed, or it's not being treated. My suggestion is it's not being treated. Why? Michael suggested it beautifully. We don't have clear definition. We don't have a clear guideline about when to go in and when to get out. We don't have good succinct endpoints of disease, when disease is stable. So this is significant. I hope to help people do a better job with that. So how do I monetize this concept? People ask me this all the time. How am I going to make money doing this? And can I make money bringing this into my practice? Well, I'll use Pat as one example because now I get different referrals into the practice. She was referred to me for elevated myeloperoxidase. And when she came to me, she had a family history of heart disease. She has a dyslipidemia, high blood pressure, sleep apnea, acid reflux, and elevated myeloperoxidase. She's taken an antidepressant, and she's taken some vitamin D and some other things. This is what she wrote on her intake form. I have elevated myeloperoxidase. So I'm going to get to the bottom line of the story, but over a year and a half, we completed perio treatment for her. We made her a sleep stabilization appliance, a Herbst appliance, so she could do something with her untreated apnea. She was managing her acid reflux, increased her aerobic exercise, cut down on her depression medication. Her lipids were continuing to improve. Her myeloperoxidase went from 654 in 10 of 2014 steadily down to 4 of 2016 to just about 310. Very nice improvement and nice steady drop over time. Did I do that? I don't know who did that. I worked and collaborated with a physician and we did it together. But what it shows is she's in a much better place and she spent about $10,000 in the office. But then I get patients like Steve. Steve was referred to me by a physician because he wanted a dentist that understood how to manage a heart issue. Steve spent $68,000 in my practice. And then I have Bill, who was referred to me by Elevated HSCRP. He had perio management and caries management. He spent $37,000 in the practice. So I can tell you conclusively that you don't make money in wellness dentistry from a dental code. You make it from a brand and a reputation that you create in the community from doing this kind of work. There's no code you can bill for that's going to produce more than your reputation and your brand as you start to change that. And then I started to think, I wonder what percent of patients are sitting in my practice that have some other disease that if I just knew a little bit about how to explain it, how to introduce them to the concept, how to screen for it, how many of those people could I help? And if you look at the CDT averages of how many people are walking around with undiagnosed disease, Susan described it, Whit described it, Michael described it. We've been bombarded with this information this weekend, and I think it's fantastic. And if you wonder where dentistry is going, this is the AES, and we've spent 2 days talking about health and wellness. I love this movement, and so I'm really happy to be part of it. This is so true. I want my patients to have wishes to go places and do other things. But Eva so eloquently performed for us before this and told her story. When you're sick, you just want one thing. It's so true. Why does the wellness movement work? Why do I have confidence this works? 3 words. It's unique, it's relevant, and it's true. We have plenty of information to go out and create some new awareness about wellness. We have a unique opportunity, and I hope that all of you in the room will join this movement. It will be hard not today to look at patients differently. So I hope I've explained that microbial profiling is valuable in periodontal disease management. It enhances communication significantly. It changes the way we educate patients. We get increased treatment effective when we start using some metric. I know it's crude, but it's the only metric we have. I know we can identify specific pathogens. Why? There's other disease considerations when you have certain pathogens. We know that periodontal disease contributes to the inflammatory process. We know there's medical cost savings potentially, and there's a tremendous collaborative opportunity, and it creates a great feel. And I can tell you another thing it does. Your patients are healthier, your practice is healthier, and your teams are healthier because of it. I really want to thank the AES for giving me the opportunity to share this information with them today. Thank you. Thank you so much. I want to thank the AES for giving me an opportunity to come and share with you what I've observed in clinical practice.